If you're watching this presentation after the fact, the recording, you can go ahead and skip forward 20 minutes. I am logging in early to get everything set up, but we're really not going to get rolling for another 20 minutes. So, All right, guys, it's about 10 minutes until start. So I came in early to get everything set up and make sure technology. All right, guys, it's about 10 minutes until start. I came in a bit early to check technology and make sure everything was working. But I am here in a captive audience for the next 10 minutes before we formally get started. So if you have any questions that you would like to post and ask that we can discuss before we get rolling, happy to do so. I've received a few questions in that we will answer towards the end if they're not answered during the webinar, and we'll get rolling in just a few minutes. All right, I see a question has come in. You'll have to tell me, I'm not sure who that is asking, but I'm happy to answer it anonymously. You're saying, can allergies be corrected by correcting imbalances in opportunistic bacteria? Um, to a good extent, yes. However, if you've had a lifetime of allergies, maybe your immune system was not balanced as a child, your body actually has created memory cells to the things that you've reacted to. So, for instance, if you have an IgE allergy to grass pollens, or if you have an IgA or IgG reaction to wheat, your body has created memory cells. And so you're always going to um, react to those substances. But as far as creating new allergies, having seasonal allergies, some of those things will reduce. Hopefully that makes sense. It's if it's a substance your body hasn't specifically created an antigen against, you should be okay. And the allergy symptoms can lessen. No worries, Matthew. I'm really okay if people want to be anonymous in the board as well. So If you're just popping in, I mentioned earlier we're going to start right at 5 o'clock Pacific Standard Time. So we have about another 5 minutes. It'll be quiet airtime unless you have questions that you want me to address during that time, but we won't get the program started until straight up at 5 o'clock. So everyone coming in can get to start from the beginning. Mary Kay, you're asking, is liposomal colostrum something you ever use to help leaky gut and modulate the immune system, and do you find it helpful? I would say that colostrum has been, I mean, first and foremost, right? Colostrum is the first protein in breast milk that babies get exposed to. And so it's intended to help a newborn seal the leaky gut that they're born with. And so colostrum plays a very important role. However, the colostrum that we take as a supplement is made from dairy. And I have found that in, excuse me, such a large proportion of my patients, dairy has become a sensitivity. And so I tend not to use colostrum only because I don't like to set people off when I'm trying to help them heal. So, what I have found to be more effective, and we'll discuss it a little bit more in tonight's presentation, is something called SBI Protect. So, the product name is SBI Protect, and it stands for Serum Bovine Immunoglobulin. So it's still made from cow. If you have an allergy to cow or beef, you may have a problem with it, but it is not dairy. So individuals that have developed dairy sensitivities and dairy allergies to the proteins casein and whey and others, they can't handle colostrum, but they can do the SBI Protect quite well. I'll also discuss with you as we look at the GI health markers on page 4. I'll make some suggestions about who might find that helpful. Okay. I see that you say you've used one before. Did you find it helpful, Mary Kay? Did it fix the problem? Okay, it's officially time to get rolling. So, welcome to GI Healing webinar number 2, Achieving and Maintaining Optimal Gut Health. Welcome. I can see you guys logging in there. Please see the reminder message that I left up in the chat box. It's near the top. To schedule your GI one-on-one consults within the next few weeks. I left a text number there for you to message if you're having difficulty logging into MindBody and scheduling that appointment as we discussed. Okay. So I know some people have been able to do it successfully and others had some difficulty, and we were able to give them some assistance. So whatever you need, you can let us know there and we'll take care of it, get you logged in. All right, so tonight, you may have noticed that the picture on the intro slide for the GI Healing webinars is a picture of downtown San Francisco. So ideally, I like to think of our microflora a bit like a hustling, bustling San Francisco or New York, another big city, okay? Dysbiosis is like when gangs start to build up in certain neighborhoods. And how we address that dysbiosis also has an impact on the greater city, okay? Lack of diversity and lack of abundance in our commensal flora allow this dysbiosis and infections to develop. And that is going to be integrally tied to inflammation, immunity, and neurotransmitter function in our gastrointestinal tract. So while there's going to be a lot going on in the presentation tonight, I hope to hit the high points in order to show you how these are each connected and how you can develop a resilient gastrointestinal tract. So these are the areas we're going to cover tonight: digestion and absorption, support in elimination and detoxification, protective barrier immune function, and neuroendocrine gut-brain function, because we covered the microbial ecosystem during webinar number 1. So, a healthy gut. What makes a healthy gut? There's a lot that goes into it, but importantly, proper nutritional substrates, micronutrients, and phytonutrients for maintenance of commensal flora, immune modulation, repair, and regeneration. So we'll get further into what are those foods, but I can primarily tell you vegetables and plant-based foods are the things that are going to feed your microflora. Yes, we need proteins and we need fats, absolutely. But it is the undigested carbohydrates and starch, cellulose, and things from the plants that actually feed the microflora. And we talked a little bit in webinar number 1 about excessive levels of fat and excessive levels of protein actually alter the microflora for this same reason. It also takes proper chewing and mastication in order to break down that food. We'll jump into that a little bit further tonight. It also takes adequate digestive juices, enzymes, and pH, the acidity of our gut. It takes an intact intestinal epithelial barrier function, which we'll get into. It requires autonomic balance and a balanced host bacteria ecology. So in digging into normal digestion and absorption and pathologies that can impact or alter that process, we'll start with the human gastrointestinal tract. And the human gastrointestinal tract, or sometimes you may see it shortened to GIT, G-I-T, on some of the slides. That stands for gastrointestinal tract. It's the second largest interface between the outside world and the human internal environment. So I said it's the second largest. Anybody guess what the first one is? I'll check back with you in a minute. But the gastrointestinal tract forms a 9-meter or 30 feet long tube from your mouth to your anus. Its surface area covers about the size of a doubles tennis court, and thus our visual here. Over a lifetime, more than 60 tons of food will pass through your gastrointestinal tract. And Marcia, you got it. Skin is the primary. And if you want to know something else, the cell type on your skin is the same as the gastrointestinal tract lining. So when you have rashes and things on your skin, we say it's usually an outward expression of what's going on internally in the environment of your gut because they're the same cells. Make sense? So, in looking at the picture, we have at the top salivary glands, and they signal the need to create digestive enzymes and produce saliva. So, if you have sufficient time between your meals, when you smell food, you'll actually start having more um, salivation happening, and literally you'll feel more fluid coming down the back of your throat because your body is starting to queue up for that food. However, sometimes we eat so frequently that we really don't trigger that process. So if ever you're hungry and ready for a meal, pay attention to that. Walk outside the restaurant first and just really smell those flavors as you step in, or step into your own kitchen as you've been cooking or prepping. Maybe things have been in the oven for a bit and you walk back in the room and that smell hits you and you're going to start salivating. It's awesome. And then your mouth, and that's where digestion actually begins. So the next question I have for you is in the chat box. Tell me, how many times do you think we have to chew our food before we swallow it? I'll get right back to that. So again, we start in the mouth with the digestive process, and then we hit the stomach. And the hydrochloric acid in the stomach assists with protein digestion and protects against invading organisms. So if there is food poisoning, or our water has bacteria in it, the first place it goes is to our stomach, and we need the hydrochloric acid there in order to protect us against those organisms coming in. And then next up is going to be the small intestine, and that's responsible for most of our nutrient absorption. So if we're having trouble with nutrient absorption, we may be having some difficulty in our small intestine. And then the next up is colon. And the colon is the primary residence for healthy bacteria. And there's what's called an ileocecal valve, or a valve between the colon, the large intestine, and one step before it, the small intestine. And if we get too many bacteria in the colon, if our populations get too abundant, there's too many of them, they can push up through that valve and get into the small intestine. That's one way. We'll talk later about other ways that we can get too many bacteria up there. So let's see. Somebody said 30, somebody said 40, somebody said 50. All right. Helen got it. It's 30. We need to be able to chew our food 30 times before we swallow it. Now, if you're kind of going, how's that going to happen? A study's been done that shows that most Americans chew their food 6 times before we swallow it. And I'm not talking about mashed potatoes here or applesauce. I'm talking about a piece of protein or a vegetable, something that you have cooked for dinner. You put it in your mouth, you need to chew it 30 times. And we'll get into more, but as you chew each bite, more saliva is released. Again, that saliva is key, and it helps stimulate the release of your digestive enzymes from the pancreas and other. The process of the chewing stimulates the stomach, and it begins producing more stomach acid, more hydrochloric acid, in order to prepare to break down the food. So by chewing each bite into smaller pieces, it also helps because the food can more easily mix with the stomach acid, and then helps it break it down into smaller pieces, smaller proteins. And what happens is if we don't break down those food particles into smaller proteins, we have a higher risk of them getting across a gut barrier that isn't intact and causing food reactions to those proteins. Make sense? All right. And then lastly, adequate chewing has also been shown to increase the absorption of fats and fiber from food and make the vitamins and minerals that they're containing more easily absorbed. So with gastroesophageal reflux disease, this is a condition of the upper gastrointestinal tract, so the esophagus. And many doctors previously assumed that gastroesophageal reflux disease is because you have too much stomach acid, and actually the opposite can be most often true. If you didn't have enough stomach acid to break down the food, it pushes up, right? It pushes up past the stomach and into the esophagus, and it burns because you also have that stomach acid, the hydrochloric acid that pushes up with it, and that's where the burning of the esophagus comes from, and that's why it hurts so bad. So GERD is a condition that develops when the stomach contents regurgitate back up or reflux into the esophagus. Signs and symptoms can be a feeling of heartburn or a burning feeling rising from the stomach or lower chest towards the neck. It's usually worse postprandially, especially at bedtime when you go to lay down, because it allows the food even more because you don't have gravity helping keep it down. And regurgitation is the effortless return of stomach contents into the pharynx. And there can also be silent regurgitation where you don't feel the acid. And that oftentimes happens when it's become chronic. So you've actually burned a lot of the internal wall of the pharynx and the esophagus. And so you have this silent reflux, and that can presuppose you to put you at higher risk for diseases of the esophagus, okay? It can also be associated as nausea and esophagitis or diagnosis esophagitis. So chronic reflux of acid contents can lead to precancerous changes in the esophageal mucosa, which are known as Barrett's esophagus. Obesity can increase the risk for GERD because the excess fat in the abdominal region can push the stomach upwards and cause that regurging, okay? Extra esophageal manifestations can include chronic cough, halitosis or bad breath, dental erosions from the acid continually coming up, and chronic laryngitis. Causes of GERD can include lower esophageal sphincter incompetence. So again, if we can't close off that sphincter, the food can push through. So patients with GERD have been found to suffer from frequent transient lower esophageal sphincter relaxations and decreased LES or lower esophageal sphincter resting pressure than with healthy controls. So poor esophageal acid clearance can happen when there's less esophageal peristaltic activity, so that food sits, it's not moving down. So we have a reduced capacity to clear the reflux contents from the esophagus. So the contact between the reflux gastric contents and the esophageal mucosa is what causes the inflammation there. So the slowed gastric emptying that I mentioned, if we have a delayed gastric emptying or partially digested food and it just sits, and it basically it can push back up. So increased length of time refluxate is available in the stomach, and it increases gastric distension, which has been found to increase the rate of transient lower esophageal sphincter relaxation. Impaired saliva flow. So remember, the things I already told you can trigger saliva is being hungry, smelling the food, and chewing every bite 30 times. So that means you need to be relaxed and conscious of your meal, which a lot of times we'll eat in the car, we'll eat at work, at our desk. We'll just kind of wolf the food down because we're otherwise in a hurry. But that reduces the amount of saliva, okay? So when we have reduced saliva, it's going to put us at higher risk for having that regurgitation again. GERD patients have been found to suffer from impaired salivary gland function and reduced saliva production. Oxidative stress. Research has shown that mucosal damage in esophagitis is mediated at least in part by oxygen-derived free radicals, and significant mucosa protective effects are found from antioxidant supplementation. So we'll talk about that again when we kind of go through suggestions for different products and things to use. Food allergies and intolerances can cause GERD. In infants and toddlers, it's often linked to dairy allergies. So you talk about these babies that they say they have colic because they keep regurgitating their food, and it can be due to food sensitivities, and dairy is a frequent one. I was one of those babies, and my mom just thought I was a fussy baby. But the doctor never really cued in that it could be my mom's drinking of milk as she was trying to breastfeed me that was causing me to literally not be able to keep the food down. So, also, patients with gluten intolerance have been found to have high prevalence of GERD. Mechanisms of how gluten exposure leads to the reflux is not necessarily known, but gluten-free diets have been found to significantly reduce gastroesophageal reflux disease symptoms and effectively prevent their recurrence. Also, a hiatal hernia, because it promotes lower esophageal sphincter incompetence and lower resting pressure in the lower esophageal sphincter. So, also things that can contribute are genetics. Okay, a genetic predisposition may contribute to the development of GERD. One study estimated that genetic influences compromise about 30% of the risk. Medications, specifically nitrates, calcium channel blockers, theophylline, morphine, meperidone, diazepam, barbiturates, and sildenafil, are all capable of decreasing the lower esophageal sphincter pressure. And smoking. Pregnancy can cause it, again, for the similar reason that people who are obese, right? Because the baby, instead of the fat, is pushing against the stomach and possibly keeping that food from emptying the way it's supposed to. But 40 to 85% of pregnant women report GERD or reflux. Psychological stress. A significant proportion of subjects with GERD have been found to suffer from psychological distress, and stress in general appears to increase sensitivity to heartburn pain. People with a higher BMI, again, that's tied to weight again, but research has found clear association between reflux symptoms and the presence of overweight or obesity. And meal timing. So I talked about when you lay down, you are going to have worse GERD impact if you're prone to it and if you haven't properly or completely digested your food. So the timing of the evening meal appears to influence the degree of nocturnal acid reflux. When you eat a high fat, high calorie meal 6 hours or more before going to bed, you're going to have less issues. So again, if you eat that heavy meal and you don't wait sufficient time, you're increasing the risk of the GERD. Otherwise, if your, say, lunch meal is your larger meal and you have a smaller meal, not real high calorie or high fat, you'll have less chances of having that GERD at bedtime. Symptom-evoking foods for GERD can include caffeine, chocolate, alcohol, and other foods like citrus, tomatoes, onions, peppermint, and spearmint. These are just all the sources from all those things I just said. And I mentioned earlier, cow's milk allergy, very, very common in infants, but it can also be a contributory factor in adults, particularly those who have a history of other symptoms that could be due to allergy, such as migraines, asthma, or perennial rhinitis. So that question that was asked earlier, Matthew, about allergies and rebalancing the gut flora, we also have to think about how food plays a role, okay? So what do we do to treat it? Conventional treatment is using histamine blockers, antacids, proton pump inhibitors, which all have potential and significant side effects. Weight loss when necessary or appropriate, avoiding symptom-provoking foods and beverages, avoiding those larger meals, especially near bedtime, raising the head of the bed so that you're not completely supine or flat when you go to bed. Natural medicine's treatment aims are to relieve the symptoms, and that would be using something like D-limonene. Research has shown that supplementing with 1,000 milligrams per day of D-limonene for 20 days reduced GERD symptoms by 86%. And melatonin. Again, because melatonin relaxes the esophageal mucosal wall so that and it actually improves the sphincter pressure. So again, dosing here, it was about 6 milligrams of melatonin, 200 milligrams of L-tryptophan, some B6, some folate, B12, was compared against omeprazole treatment for 40 days. And all patients in the dietary supplement group reported complete relief of GERD at 40 days. And they actually, so the test results were taken at 40 days, but they actually reported relief by day 8 versus 65%, 65.7% in the omeprazole group. Additionally, in order to decrease esophageal inflammation and promote esophageal healing, we can use things like there's some herbs listed there, and it just slipped my mind. The one we talked about with again, when I'm trying really hard to think of something, it won't pop in, but I'll think of it in a minute. The one we were talking about for gastric ulcers also can help here too. But curcumin. So GERD patients on proton pump inhibitors took 2 grams of curcumin per day for 2.5 months. And after 2 weeks, all subjects were able to come off of their proton pump inhibitors. 79% remained completely asymptomatic over the 2-month follow-up period. So even after they stopped taking them, they were still asymptomatic. Melatonin. Research has found that melatonin is capable of healing even severe gastroesophageal or esophageal ulcerations, and phytonutrients and antioxidants. Remember, we talked about coming from plants, right? That's where we're going to get phytonutrients and antioxidants. So brightly colored fruits, vegetables, and whole grains all assist with that as well. Eliminate and minimize exacerbating factors. We talked about the dietary factors, timing when eating, smaller meals, avoiding fluid consumption with meals. Again, because when you drink water with meals, it dilutes the gastric acidity in the stomach. So if you want to better digest your food, you're better off to minimize liquid. You can have it available, because if you don't chew that food properly, it might get a little bit stuck in your throat, and then you use the water to wash it down. But instead, we should just be chewing our food more, right? And not using that water unless we have to. Water is wonderful as a liquid throughout the day, but try to minimize it at meals. Change the evening meal time to earlier in the evening, at least 3 hours before bed. Consider the possibility of celiac disease as well if you're having GERD, and dairy-free diet. Eliminate or minimize exacerbating factors of lifestyle. So the weight loss we talked about, stop smoking, raise the head of the bed, and then antioxidant defense to prevent against the esophageal cancer can include beta-carotene supplementation. We already talked about improving salivary gland function by chewing the food. You can actually chew gum after meals, 30 minutes after the meal and before bed to help as well, because that's more salivary production. Just be really careful, because so many of the gums have the fake sugars and things in them, right? So careful there. But potential role for sialagogues as a mouth rinse to help. And then speeding up the gastric emptying, so the food's not sitting there, right? So avoiding foods and drinks that slow gastric emptying, like fatty foods and alcohol. And then there are specific probiotics, again, strain-specific probiotics that help speed gastric emptying. Now, if you're someone who has more diarrhea, you certainly don't want to use these probiotics. But if you're someone who has GERD, tends to err towards more constipation, and we need to be able to get that food moving better, these will help. Okay. So supporting your nervous system, anxiolytics like passion flower, lavender, and kava can help calm so that you're able to better digest. Adaptogens like rhodiola, schisandra, withania, and panax ginseng. And nervous system tropho-restoratives like motherwort, vervain, and green milky oats. Okay, those are just all the sources there. So now we're moving to the stomach, where we're going to have that hydrochloric acid being released in order to assist with protein digestion and also protect against invading organisms, as we mentioned. And pepsin is also released for protein breakdown. So a healthy stomach secretes hydrochloric acid. It's used to activate pepsin, as I just mentioned. It's an enzyme that plays a role in protein digestion. It also enhances the absorption of various micronutrients, including iron, zinc, copper, folate, which is B12, vitamin B3, and beta carotene. And it's critical for being able to release B12 from the protein. So therefore, if someone is low in hydrochloric acid, they're not going to be able to get B12 out of their food. However, it will not stop them from being able to absorb B12 from a vitamin supplement. So some people have said that if your hydrochloric acid or intrinsic factor isn't working well, that you can't take a B12 supplement. You have to use like shots and things, and that's absolutely wrong. You can still absorb the B12 from the supplements. Okay. Hydrochloric acid also plays a role in the liberation and subsequent absorption of bioactive compounds in different herbs. The gastric phase of protein digestion can be impaired if pancreatic enzymes aren't being produced. And potential consequences of incomplete protein digestion include suboptimal protein nutritional status, something that we would see like on a NutrEval or a plasma amino acid study, and increased absorption of allergenic macromolecules. I mentioned that earlier. So again, if we're not breaking down those proteins, right, if we're not chewing them, mashing them up, making them smaller, or having hydrochloric acid to break them down even further, then we have a higher risk of those food proteins or particles triggering some allergic responses. Okay. Achlorhydria, which is the absence of gastric acid, or hypochlorhydria, which is inadequate or lowered levels of gastric acid secretion, can result in decreased absorption of various nutrients that we talked about in the last slide and potentially lead to nutritional deficiencies. So hydrochloric acid also serves as a barrier function by killing various pathogenic microorganisms that might otherwise colonize the gastrointestinal tract. Things like, we talked the other day in the previous webinar about the need for the gastrointestinal tract to be acidic, right? We want our blood and our urine to not be as acidic as the gastrointestinal tract, but the gastrointestinal tract, we expect it to be acidic at like a 3.0 or less, okay? Probably nothing more than a 4.0. People with hypochlorhydria are at increased risk of having bacterial and fungal overgrowth and parasitic infestation of their gastrointestinal tract. And concentrations of nitrites in gastric juice is significantly higher in people with hypochlorhydria. And the nitrites set us up for higher risk of cancer. So what symptoms might someone have if they're hydrochloric acid deficient? They may have none. Okay, a lot of people just simply don't know. But they may feel unusually full after meals, even if they're small or moderate sized meals. They may feel really full. Oftentimes I hear from a patient that I just eat a few bites and I just don't feel like I want to eat anymore. That's a good hint, okay? Belching, flatulence, morning diarrhea, diarrhea after heavy meals, constipation, heartburn, indigestion, and that sensation that food sits a long time in their stomach. We naturally get more deficient in hydrochloric acid as we age. It slows down. So we've already talked about all those things that we can do to help increase it, right? The smelling of the food, the chewing of the food, the relaxing at meals. We can help our body create more and we can replace it. But I don't like to, in life or in practice, just tell patients to go replace everything that's not working in their body. I'd like to help their body learn how to fix it, okay? But this is one of those things that with aging, we do reduce the amount of hydrochloric acid that we make. Atrophic gastritis caused by autoimmune destruction of parietal cells, H. pylori infection, or chronic atrophic gastritis can progress to gastric atrophy, at which point the hydrochloric acid deficiency may be irreversible. So that's why we don't want these things to sit around in a chronic place, right? We want to find them, catch them, and turn them around. Severe iron deficiency and after an episode of gastroenteritis or inflammation can cause hydrochloric acid deficiency. So hydrochloric acid deficiency has also been found at different rates with multiple conditions. So you can kind of take a peek there. So someone who's had childhood asthma has a 73 to 80% chance of having reduced hydrochloric acid. Pernicious anemia, 100%. But then something like dermatitis hepatiformis, it can range between 25 and 90%. So there was just a huge range there of who is impacted by it. So what do we do to treat it? GI symptoms often improve immediately after an effective dose of hydrochloric acid is reached. So where it says here, betaine HCl or glutamic HCl, those are two different types of hydrochloric acid. And I'm not thrilled about this hydrochloric acid challenge that's kind of listed here. I've been learning a lot about it, and there's just so many people who don't react to the hydrochloric acid. So I really don't like to encourage people to use more than 3 caps per meal. I just don't. It's too much. So up to 3 caps per meal, especially the heavier fat and higher calorie meals, they're going to need it. But drug interactions, so ketoconazole, for instance, depends on the presence of gastric acid for absorption, and the rate at which certain drugs are excreted in the urine is influenced by urinary pH, which may in turn be altered by acid replacement therapy. In other words, if you supplement with HCl, you have a potential to influence both the absorption and urinary excretion of different medications. So just heads up there. If you're on prescription medication, adding in hydrochloric acid can alter your current dosing. Niacinamide has a strongly alkalinizing effect. So niacin has about half the alkalinizing effect of niacinamide. So if you're using niacinamide or niacin, it may increase your need for more hydrochloric acid replacement. Get that? So got to be careful because niacin is going to reduce the effectiveness of the hydrochloric acid because it's more alkalizing. So next up is gastritis. And gastritis, especially chronic gastritis, is caused by inflammation of the stomach lining, okay, that's been there for a while. That can be caused by H. pylori, excessive alcohol consumption, use of non-steroidal anti-inflammatories, chemotherapeutic agents, and autoimmune response. It can also be associated with other diseases like cirrhosis of the liver and renal failure. It can progress to chronic atrophic gastritis, which can cause hypochlorhydria and various nutritional deficiencies that we've already chatted about. And this is the most common cause of pernicious anemia. Patients with H. pylori gastritis or autoimmune gastritis are at increased risk for developing gastric cancer. Often, gastritis can be asymptomatic, but some patients experience gastrointestinal symptoms, and treatment of the gastritis is going to vary according to the cause. And that's exactly why we're here tonight, looking at your own stool tests so we can determine what are the things that can be causing. And remember, what we're not looking at on that piece of paper that you have is your diet. So tonight we're going to dive a lot further into how the food that you eat, how you eat, how much you eat, all those things can play a role in the health of your gastric mucosa, in addition to the pathogens and the opportunistic bacteria that we're looking at, okay? So dietary factors, higher intakes of fruits and vegetables, and higher density of or higher dietary intake of vitamin C were associated with lower prevalence of atrophic gastritis. So again, those protective nutrients, right, from the plants that I've been talking about, higher milk consumption was associated with an increased prevalence of gastritis. Food allergies, again, cow's milk allergy was implicated as a cause of erosive gastritis and gastroduodenitis in infants. Vitamin C, so vitamin concentrations of vitamin C in gastric juice was significantly lower in patients with chronic gastritis and chronic atrophic gastritis than in people with normal gastric histology. Low levels resulted from impaired secretion of vitamin C into the gastric juice. So 500 milligrams of vitamin C twice a day for 2 weeks increased the concentration of the vitamin in the gastric juices, but levels were still lower than those of normal subjects. So we're talking somebody who's had this a chronic issue, right? Iron. Because hydrochloric acid plays a role in iron absorption, patients with chronic gastritis who are hypochlorhydric are at risk of developing iron deficiency. H. pylori infection can cause iron deficiency by competing with the host for available iron. The bacteria uses it up. N-acetylcysteine, supplementing with 1 to 4 grams per day of N-acetylcysteine for 4 weeks resulted in endoscopic improvement in patients with chronic gastritis. Okay, also B vitamins. So before refined grains were enriched with B vitamins, using liver extract in patients with pernicious anemia or atrophic gastritis resulted in complete or almost complete normalization of atrophic changes in the gastric mucosa. Some patients with gastritis are at risk of developing vitamin B12 deficiency, like we talked about, because of a decrease in hydrochloric acid secretion. And we can talk about it, but my favorite B12 supplements are actually sublingual or just a lozenge that you suck on, because you start to absorb it already through your buccal mucosa, through your mouth, the cells in your mouth. It's already getting to your bloodstream before you would otherwise swallow it, and it has to go to your stomach and then into your small intestine for absorption. Make sense? So some clinical features of maldigestion, right, not being able to digest your food, could include steatorrhea, which is a high steatocrit on your page 4 under your health markers. If you have a high or somewhat high steatocrit, you're having trouble digesting your fats. You may have abdominal discomfort, distension, flatulence, so your stomach gets a little bloated and you get gassy, decreased absorption of nutrients. So on a NutrEval or other nutritional test, we may see that you're not absorbing your nutrients. You may have edema. You may have bleeding tendency if you're not able to absorb vitamin K. You may have weight loss or failure to grow in children, growth failures. Again, causes can be the mucosal diseases, dysbiosis, pancreatic enzyme deficiency, or bile salt deficiency, which we're going to get into in just a minute. So conjugated bile acid deficiency can cause malabsorption of fat, including fat-soluble vitamins, because they travel around in the fat, calcium, and magnesium. So causes of conjugated bile acid deficiency can be liver disease, biliary obstruction, SIBO, ileal disease, and cholecystokinin deficiency, or CCK, which is one of the hormones in the gut. And lastly, I would say if you don't have a gallbladder anymore, you can have bile acid deficiencies because your liver makes it, right? But your gallbladder has to store it, so it might not be released at the time that you need it, which we'll get into that a little bit more. So pancreatic insufficiency, the foods and vitamins that you're not going to be absorbing include fat, protein, carbohydrate, fat-soluble vitamins, and B12. And that pancreatic insufficiency can be caused as a congenital issue. You can have chronic pancreatitis, which is inflammation of the pancreas, pancreatic tumors, hyperacidity due to inactivating the pancreatic enzymes. Reduced mucosal digestion, right? That's going to cause a deficiency in absorbing carbohydrate and protein. Those can be caused by Crohn's disease, celiac, brush border enzyme deficiency, like lactase, right? If you have a difficulty digesting lactose because you have a lactase deficiency, that's the enzyme that has to break it up. And then lastly, intraluminal consumption of nutrients. So that's going to help happen with B12 and your macronutrients. And that's going to be caused by SIBO or parasitic infections. So now we're moving down to the small intestine. There's a lot that can go on here, right? Did you ever realize how much can happen here just from a stinking bacterial dysbiosis? Yeah, it's a lot. So now we're into the small intestine, and this is where we have to absorb the nutrients. So first we had to digest them in the stomach, mouth and stomach. Now we have to absorb them. So pancreatic enzymes are needed, and they're released into the small intestine lumen by a complex regulatory mechanism. It involves elements of the enteric nervous system, which is your vagus nerve, and hormonal systems. Impaired regulation can result in poorly coordinated or insufficient release of the pancreatic enzymes, and the result may be incomplete protein, fat, and carbohydrate digestion, leading to maldigestion, and you may have high fat in your stools. Again, that's steatocrit on page 4. Okay. Bile, as I said earlier, is made in the liver and it's stored in the gallbladder. Digestion and absorption of fats and fat-soluble vitamins are reduced when bile acid availability is diminished or poorly timed with pancreatic lipase secretion. Bile acids are also important metabolic signaling molecules and play a role in reducing small intestinal bacterial overgrowth. So again, if you have insufficient bile, you can develop SIBO. There's another cause, okay? It's the combination of elastase and steatocrit markers on your lab testing. So those of you who did the GI map specifically, on page 4, you have markers for elastase and steatocrit that give us an indication of how well your pancreatic enzymes are functioning. So fat digestion primarily occurs in the small intestine, a little bit in the stomach. Bile salts, again, break the fat into smaller packets for enzymatic breakdown. Again, you need sufficient bile to have those bile acids or bile salts. Liver congestion or inflammation from toxic load or cholestasis or stagnant bile can result in poor bile delivery. A gallbladder removal due to cholestasis can also hinder fat digestion by allowing constant trickle of bile rather than a bolus when you need it. So you don't need a trickle of bile all during the day. You need a bolus of bile when you eat, okay? Fat maldigestion symptoms can include gas, bloating, foul smelling, and floating stools. Digestive enzymes taken as supplements typically can assist these patients. But again, let's look back to your results again on page 4. If you have, I don't know why I had a note here. So if you have low elastase, okay, if you have low elastase, it can mean that you have insufficient pancreatic enzymes that are being released. A high steatocrit indicates fat present in the stools and can indicate a couple of different things. So if the steatocrit is high and it occurs with a low elastase, it can mean insufficient pancreatic enzymes, specifically lipase. But if you have I'm going wrong here. Okay, so if you have a high steatocrit with normal elastase, it can indicate high levels of fat in the diet, like overconsumption of fat. Your body's not able to handle the amount that you're eating, which we know compromises the gut microflora. Or it can mean insufficient bile production and release in order to sufficiently break down the fat in the diet. So again, that's high steatocrit with normal elastase. Then we're saying it's not the pancreas, it's the bile. Make sense? All right. So how do we increase bile secretion? Choline is one thing. It's a nutrient, and it's made in the liver using an enzyme that's called PEMT. And me and many of us have slowed PEMT enzymes. So we need this choline because it works closely with the bile salts to break down the fats. Low levels of choline may cause bile stagnation. There's choleretic, I can't even say it, choleretic and cholagogues, which stimulate bile secretion. These are bitters, right? So there's like Old English bitters help to stimulate the bile production. There's warm lemon water on an empty stomach first thing in the morning. So here, a little bit different. The warm lemon water on an empty stomach first thing in the morning is going to increase bile production, okay? But we still need to time it right. So the warm lemon water on an empty stomach first thing in the morning is going to increase production of bile in the liver, and then we still need to time its release. So then the choleretic or cholagogue could help with that, or using the choline to get the body being able to do the whole process itself. And lastly, there's bile salts, which we can take. Those are usually extracts from ox bile or other sources. And then lastly, coffee enemas can be done to help improve bile flow, prevent the reabsorption of bile and the toxins that are contained in the expelled bile. So that's one of the ways we get toxins out of the body is through the bile. And if we're not getting rid of the bile, if it's sluggish and it's sitting there, it's just holding on to them. So getting that bile moving, we can talk about that further if you want, but that's there. So your elastase marker, we talked about that. If it's low, it's an indicator of pancreatic exocrine insufficiency and possibly pancreatitis. Symptoms can include appetite loss, right? You're not breaking down the food. It's just kind of sitting there. You're not really getting hungry because the food's just putrefying. It's just kind of sitting around. Treatment for that can be oral pancreatic enzymes and working to reduce inflammation in the gastrointestinal tract and possibly liver so that you can turn that problem around, right? And steatocrit, we mentioned that one. It's a marker of steatorrhea or elevated fat in the stools, can be influenced by your diet, overall fat consumption we talked about, and can also be caused by pancreatitis. And what we didn't say here is it can also be caused by insufficient bile, right? So it's quite circular because high fat in the diet alters the gut microflora, and it's the balanced gut microflora that prevents elevated oxalate levels. So oxalates can play a role in kidney stones, gout, rheumatoid arthritis, certain forms of chronic vulvar pain, it's called vulvodynia, and more. So that balanced microflora that we're aiming for helps to prevent high oxalates and therefore prevent the kidney stone formation. So symptoms of malabsorption as opposed to maldigestion that we talked about before, okay? These might be anemia, and those can be due to malabsorption of iron, B12, or folate. We can get edema due to a poor absorption of protein. We can get tetany due to poor absorption of calcium or magnesium. We could have milk intolerance due to poor absorption of lactose. And we could have bleeding when you're brushing your teeth due to insufficient absorption of vitamin K. Okay. So now we're moving down. Now we're into the small intestine again, looking at small intestinal bacterial overgrowth. So SIBO has gone from being a rare condition that was seen with gastrointestinal surgery patients to being the cause of everything gastrointestinal related over the past 15 years. Like everybody, like there's tons of people now that if you say you have IBS, oh, it's SIBO. It's SIBO. And the problem is they're doing a lot of excessive and potentially harmful healing practices in doing that. So we need to be careful. The popularity of naming it has coincided with the rise in paleo diets and other low carbohydrate diets. Is there a correlation? Could be. What is it? It's a heterogeneous syndrome characterized by an increased number and or abnormal type of bacteria in the small bowel. So again, the tests that you're looking at are looking at the abundance and diversity of bacteria primarily in the colon. So on page 2, where you're looking at the commensal flora numbers, we're not really getting a sense of what's going on in the small intestine. So that's why we talked about some other markers that we might see on the NutrEval. I'm sorry, on the GI map. So specifically in a lab, they say it's greater than or equal to 10 to the power of 5 colony-forming units of the bacteria, of any bacteria, in the proximal jejunal aspirate. And there's 2 different types of SIBO. There's gram-positive bacteria from the upper respiratory tract and oral cavity, or there's colonic coliform bacteria. So again, coming from different directions, right? They're either coming down or they're going up. 2 different, And then potential causes can be overabundance of bacteria in the colon pushing back to the small intestine through the ileocecal valve that we talked about, that overcrowding. The overcrowding can also be caused by heavy metals. I can get into that later, but sluggish bowels, food not moving through the small intestine to the colon. Again, that can be due to the vagus nerve, stress, H. pylori, or other. Heavy metal recycling, when you can't eliminate them, it just keeps getting dumped back into your small intestine. And low stomach acid, which allows for increased overgrowth. Okay. Proposed signs and symptoms of SIBO include bloating, flatulence, abdominal discomfort or pain, frequent belching, and diarrhea. And systemic symptoms might include weight loss or fat in the stools, arthralgia, polyneuropathy, and that's secondary to the B12 deficiency, acne rosacea, macrocytic anemia, that's where the blood cells are larger as opposed to microcytic when they're smaller, and iron deficiency anemia. Risk factors for SIBO include those proton pump inhibitors that we mentioned earlier. So you might have GERD and you take PPIs and now all of a sudden you have SIBO, right? You just complicated your situation even more. Narcotic use, opiate painkillers, gastrectomy, chronic pancreatitis, dysmotility, AIDS, diabetic neuropathy, and simply getting older, because again, that decreased hydrochloric acid can allow this to occur. Small intestinal disorders like small bowel diverticula, Crohn's disease, celiac, short bowel syndrome, heavy metal enteropathy, radiation enteropathy, or ileocecal valve resection, and large bowel disorders like acute diverticulitis can all play a role. So the diagnostic dilemma comes in: how do we diagnose this thing, right? It's in a systematic review of diagnostic tests for SIBO. The researchers concluded that there is no validated diagnostic test or gold standard for SIBO, period. Most commonly recommended test is in the blogosphere online, right, is the lactulose breath test. Prior to being patented for the assessment of SIBO, the lactulose breath test was widely used as a non-invasive test to evaluate oral-cecal transit time. So in other words, there was a purpose for it. How long does it take for food to get from your mouth to the toilet? Okay, that's what the SIBO or the lactulose breath test was used for. And the problem with that is, sorry, I'm jumping ahead. We'll get there. The problems with the lactulose breath test, it's very, very, very poor specificity, poor sensitivity, and low diagnostic accuracy. So people with Asian backgrounds have a quicker small bowel transit time. So the lactulose breath test just wouldn't even be useful for them. It's going to be a false positive, okay? there's high rates of false positives. 35% of patients without SIBO, didn't have it, had a positive test. Okay, but it can also miss many cases of confirmed SIBO. So that's a false negative. And simply some bugs or some bacteria have a limited capacity to eat lactulose. So you might have a SIBO that involves bacteria that aren't going to use the lactulose. So again, it's not going to be reflected. It can't differentiate between different types of SIBO. And one would say, is there a commercial bias? Is the lactulose breath test for SIBO, because it's patented, is it being pushed more, right? So there's another test that's called a jejunal aspirate and culture. And again, this is an imperfect gold standard, but it is the current used gold standard, but it's imperfect. Samples only the duodenum or upper jejunum, and there's several species of bacteria that are not able to be cultured using conventional culture-based techniques. I talked to you about that the other day. And lastly, there's one called the glucose breath test. And that one has a 27% sensitivity, but 100% specificity. What does that mean? If the test comes out positive, you've got it. But if the test comes out negative, it doesn't mean you don't have it. But this one isn't going to have a lot of false positives with people end up getting aggressive treatments for something they don't even have. Make sense? So treating SIBO, removing contributing factors, pharmaceutical agents that may have contributed, so getting them out, PPIs, right? Get it out. Antimicrobial therapy, and there's a star here because antibacterial herbal medicines, they work differently against different bacteria, but people that take a lot of antibiotics for SIBO tend to have a lot of relapses because the antibiotics don't necessarily get rid of the right bacteria, and it worsens the body or the bacteria in the body for antibiotic resistance. So there can be more significant shifts in the gastrointestinal ecosystem, and it can take 2 to 4 years to normalize. Remember, we talked about that after a single course of antibiotics. And the metabolic activity of the bacteria may take up to 16 months to normalize. The more antibiotics used, the greater the derangement. Potential long-term health consequences can include what we call a disappearing microbiota hypothesis, where they're saying you have a difficulty being able to regrow certain populations, right? We address that. And an increased risk of breast cancer tied to decreased microbial diversity. So also increased mortality from breast cancer and increased risk of prostate, breast, lung, and colon cancer. So treatment using prebiotics, and this is against everything that you will see in the blogosphere. They're like, oh, every prebiotic is bad for SIBO. Well, hang on. Most of the stuff they recommend online, yes, because they're recommending these non-specialized probiotics and prebiotics. We'll get in there, but food that isn't specific is going to be problematic. So prebiotics, the galacto-oligosaccharides that we talked about, GOS, it decreases methane production. Okay, and there's a specific bacteria that I will point out to you on page 3 of the NutrEval that we talked about. I'm sorry, I keep saying NutrEval. On the GI map, page 3, under the opportunistic bacteria, under the additional dysbiotic overgrowth section, the last one that's called Methenobacteriaceae. Several of you had that one slightly elevated. I can't remember if anybody actually had it high, but we had multiple that had a dysbiosis there. So if that one is slightly elevated, you have a dysbiosis, you might be having this methane gas production, okay? And what this is saying is the galacto-oligosaccharides, or GOS, helps decrease methane gas, okay? Lactulose decreases presence of SIBO, decreased serum endotoxin levels, sped small bowel transit time, and healed leaky gut. Check that out again, right? And then lastly, there, partially hydrolyzed guar gum, or PHGG, decreases methane gas production, And a combination of PHGG and GOS did fantastic in the research and is tolerated well by most patients. So treatment for SIBO for probiotics, again, very strain specific. Taking a broad spectrum probiotic that is not strain specific can make it worse. Hear me out there. But with specific probiotics, we might be able to do some good things. So stimulating the migrating motor complex, again, moving the bowels, selective antibacterial actions, rebalancing the ecosystem, reducing visceral hypersensitivity, calming down the viscera specifically, decreasing the intestinal inflammation, and helping heal a leaky gut. And the two that we saw in research here were Lactobacillus rhamnosus GG, or specifically Culturelle, Health and Wellness Probiotic, and Culturelle. And the last one is the Lactobacillus plantarum 299V. And there's two now that I'm using. I'll look up the other name, but one is Metagenics Ultraflora Intensive Care, and the other one, I will have to look it up. There's another 299V one that I use. Good question, Marcia. Culturelle, I do not believe Culturelle is dairy. We'll have to look into that one again. I don't think it is. So nutritional supplementation, polyphenols, grape seeds and skins, and ground flax seeds, 1 to 2 tablespoons daily help. Diet manipulation, we don't know because no dietary approach has been clinically proven to work in the management of SIBO, despite what many will say online. And specific carbohydrate diet and low FODMAP diets are widely recommended to treat SIBO, but the assumption is that all bacteria consume only carbohydrates, and that's not true. Some commonly isolated SIBO microbes readily consume protein, specifically E. coli, Bacteroides, and Clostridium. So yeah, there is no specific diet that has been shown. Small intestinal motility enhancers. So dysmotility is a strong independent risk factor for SIBO, right? The sitting, not moving. So lactulose can be exceptionally helpful for that. The right symbiotic, that's where the Lactobacillus rhamnosus GG came in. And Bifidobacterium lactis BB12 with inulin. So there is a particular probiotic that has those all combined together. And then the right probiotic strain. Here's two more. Bifidobacterium lactis DN173010 or Bifidobacterium lactis HN019. Reducing stress, meditation, breathing exercises, exercise in general, minimizing snacking, minimizing snacking. The migrating motor complex is interrupted by frequent eating. So again, you might be somebody who benefits greatly from intermittent fasting, where you don't eat for 12 to 16 hours, and then you have an 8 to 10 hour window where you maybe eat 2 healthy meals. Okay. Gut healing agents like L-glutamine. And now we're moving to the colon, right? The large bowel. Colonization of a healthy microbiota. The colon is where the majority of our commensal and pathogenic flora reside. Bacteria indiscriminately are wiped out in this area with antibiotics. Some herbs can be equally indiscriminate and should be saved as a last resort. So then we have conditions in the colon, which are irritable bowel syndrome and, irritable bowel syndrome and inflammatory bowel disease. I need to fix that. So irritable bowel syndrome, also called spastic colon or originally called mucus colitis, is really an umbrella term. It is basically a term given for a gastrointestinal issue where they can't diagnose what it is. So it's a syndrome absent a pathology. They can't figure out what it is, so they're just going to call it IBS. So there's no pathogens, there's no elevated calprotectin, but it may be due to dysbiosis. Signs and symptoms can include abdominal pain, bloating or abdominal distension, excessive flatulence, passage of mucus in the stools, and constipation, which would be less than 3 bowel movements per week, or diarrhea, which is more than 3 bowel movements per day, or alternating constipation or diarrhea. So the diagnosis is, as I said, is one of exclusion and requires the absence of any other gastrointestinal tract pathology. It's absence of any reproducible or accepted biological markers that can be used in the diagnosis of IBS, nor is there a simple diagnostic test. So these problems have stimulated the development of symptom-based diagnostic criteria, and they call it the Rome 4 criteria. So it's recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following: related to defecation, associated with a change in frequency of stools, associated with a change in form or appearance of stools. It's crazy. If you haven't had the symptoms for 3 months, it technically can't be called IBS. But there's different subtypes. One is constipation predominant or CIBS. One's diarrhea predominant or DIBS. There's mixed IBS and unsubtyped IBS. So this is a Bristol stool chart. When we say, what does it look like when your stools are in the bowl, when you are having a normal stool versus a constipated stool versus a diuretic type stool, okay? Starting from the top, that's type 1. So that's extremely constipated, okay? Type 2, where it is lumpy and sausage-like, but maybe still kind of formed, is slightly constipated. And then type 3 is a sausage shape with cracks in the surface. That's normal, okay? So there's a little bit of a difference between type 3 and type 2. And maybe you have a type 3 or a type 4 with a few separate hard lumps that come out early. What does that mean? It means you're a little dehydrated. So the water starts being reabsorbed from the distal colon. So the farthest area, the water is going to start getting reabsorbed first. So you may have a few hard separate lumps that come out, and then you have a type 3 or type 4. So that just means you're getting a little dehydrated. That's kind of a heads up to drink more water. Okay, type 5 is where you have soft blobs with clear-cut edges, and you're lacking fiber. And type 6 is where you're having a mushy consistency with ragged edges, and that's due to inflammation. And type 7 is just pure liquidy consistency with no solid pieces, and that's inflammation. And it may even be, like it's showing here, more yellow in color rather than the nice healthy brown. And if it gets super yellow or even green, that's a bile issue. Okay. So having to do with IBS, it tends to cause an enhanced visceral perception. So we're going to get a little bit further on about the gut-brain connection, but there's a whole lot more messages from the gut to the brain than the other way around. So in people with IBS, that communication system is on high. So the messages from the gut to the brain are on speed dial, okay? There's generally a low-grade inflammation. IBS patients don't show identifiable inflammation per se on colonic biopsies. Some do show increased expression of inflammatory markers, enterochromaffin and mast cell, increased intraepithelial T lymphocytes, and increased mucosal interleukin 1 beta. The mild mucosal inflammation is theorized to cause local disruption to neuromuscular function. So it's a big communication telephone system between your gut and your brain. Altered gut motility. So we talked about this when it's just kind of sitting there. It's not moving very well. That can be the constipation IBS, significant delays in overall colonic transit and decreased numbers of fast and propagated colonic contractions compared to healthy controls. And then also the diarrhea IBS is going to have more rapid ileocolonic transit and colonic transit time. And you could alter between both, especially if you have food sensitivities, because when you eat that food that triggers the body to have increased inflammation, you may have the diarrhea type, okay? And that's not a hard and fast either, because for some people that food inflammation causes constipation. So you may have impaired transit time of intestinal gas, so backup in gas causing the bloating. You could have an altered gastrointestinal microflora or dysbiosis. So colonic fermentation studies found patients with IBS to produce significantly more colonic hydrogen than healthy controls, as well as having altered fecal short-chain fatty acid profiles, lowered fecal concentrations of bifidobacteria and lactobacilli, and higher concentrations of Enterobacteriaceae. And I would say of all of you on the call tonight, I would say most of you have IBS because we see the dysbiosis there. A few of you have a little something else going on, and we'll talk about that. Don't fear it, know it, and then know how to deal with it. Okay, and we'll dig into some of the more specifics when we do your one-on-ones, but you may see some hints of that tonight as we're going through this. Risk factors for IBS can include familial disposition. It may contribute to the development of IBS in some patients. And again, is that because they inherited the gut microbiota of their mom? Is it because they eat the same inflammatory diet or foods that their bodies react to? Familial doesn't always mean genetic, okay? The predisposition may not be disease specific, but more related to alterations in the responsiveness of the central nervous system to stimuli. And acute gastrointestinal infection, so post-infective IBS, so food poisoning or water exposure, right, from either your own well or city water supply, or going swimming in a lake or a river that was had some bacterial counts that your body didn't get over. That could cause acute gastrointestinal infections. And antibiotic use, likely mediated via antibiotic-induced alterations of the gastrointestinal microflora. And stressful and traumatic life events can literally trigger an IBS. And so kids who have lived through a lot of early trauma can create and get stuck in an IBS situation from childhood. Okay, and they could have remitting bouts. It may get normal at certain times, and then the stress goes up a little bit, and their body has a memory, and it goes right back to the gut again. So treatment aims with IBS are to optimize the gastrointestinal microflora, everything we've been talking about, okay? Normalizing bowel habits. And so think about that chart I showed you guys a few slides ago. You have it there. But you can also pull it up bigger on the internet. It's called the Bristol stool chart, and you just pull it up. And you know what? Talk to your kids about it. Like, seriously, if your kids don't know what normal is, how are they going to tell you when there's a problem? So it shouldn't be a shameful discussion. We are one of the only cultures in the world that doesn't look at our bowels as a function of the health of our current body. So get over it. So managing the gastrointestinal symptoms, supporting the nervous system, decreasing gut inflammation and diminish visceral hypersensitivity, improving liver function, okay? Assessing and managing food allergens and food intolerances. So in optimizing the microflora, we can look at the prebiotics. We talked about the galacto-oligosaccharides. We also talked about lactulose. Probiotics, we talked about the Lactobacillus plantarum 299V. There were others that were in there too, but Lactobacillus 299V. Antimicrobials, probably not. I mean, we could test for SIBO. If it's present, then treatment may be indicated, but not really for IBS. Normalizing bowel habits. So again, if you have constipation type IBS, fiber, fluid, and exercise, increasing stool frequency and softening the stools. Herbs such as slippery elm and licorice root, lactulose, and Bifidobacterium animalis. If shown to be a methane producer on breath testing, things like garlic, galacto-oligosaccharides, and partially hydrolyzed guar gum and polyphenols, and the Lactobacillus reuteri DSM 17938. Yeah, that's how specific it gets. All right, normalizing bowel habits. Again, if it's the diarrhea type IBS, if anxiety plays a role, okay, we can support that using nutmeg, Piper nigrum, dragon's blood, and then we need to consider other potential causes like celiac, mild enteropathy celiac, non-celiac gluten sensitivity, SIBO, fructose intolerance, lactose intolerance, and intestinal parasites. Again, managing gastrointestinal symptoms, we want to look at the abdominal pain and bloating. We could use things like oligosaccharides, cardamom, caraway seeds, fennel seeds, ginger root, and lemon balm. We can support the nervous system with things like valerian root, lavender, verbena officinalis, schisandra, rhodiola, and eleutherococcus. Thank you. We can decrease gut inflammation and diminish visceral hypersensitivity using things like iberogast, licorice root, turmeric, and melatonin. Yeah, Marcia, sorry, it can totally help relax the gut and return normal motility when there's anxiety issues. Yeah. So improving liver function, the liver can be compromised due to candida, heavy metals, glyphosate, oxalate. We can support it and detox when we're able, but honestly, I like to support the liver, but not aim to do any type of active detoxing until we've diversified the gut flora better, because it can take a toll on the gut as well. Those circulating toxins dump back into the small intestine, which we mentioned a little bit earlier. Assess and manage food allergens and intolerances. So this says IgG testing with a question mark. It can be done. There's also something called an elimination diet where you can remove common food allergens or common food intolerances. Role of gluten. So many people have gluten sensitivities and don't know it. You can actually not have a gluten sensitivity. You may not have an IgA response, but it can still cause an elevation of zonulin, causing a leaky gut, allowing you to then react to other food proteins. So it can be a little bit of a booger, that one. Role of FODMAPs if fructose intolerant. And again, if you did a low FODMAP diet, we would want to keep it very short term while we're fixing the problem, because it's a very restrictive diet. And if you remember my saying to you during the first webinar, I don't like to allow diets to be super restrictive for very long, because that's going to reduce the diversity and abundance of the gut flora again. Okay. So warning signs. Get further testing if there's blood in the stools, weight loss, or fever. Okay. Nobody here showed up with elevated occult blood in their stools. So it's not something where I'm going to flag any of you. And even if I do have a patient that has a one-time measurement of occult blood in the stools, we'll talk about potential causes, whether they maybe have hemorrhoids, internal or external, and we'll test again within a couple months. And if it's not getting better, then we'll send them out for something like a colonoscopy. Okay, but nobody here was there. Irritable bowel syndrome versus inflammatory bowel disease. So IBS, again, generally does not include inflammatory markers like calprotectin and lactoferrin. It's a syndrome. It's a functional disorder rather than a disease. Okay. IBD, or inflammatory bowel disease, is inflammatory in nature. It can be tracked with calprotectin and lactoferrin. And there's different types. And then we start to look at differentially diagnosing what type is it, because how we treat it matters based on which type it is. Things like Crohn's disease, ulcerative colitis, and indeterminate colitis. Okay. So when we talk about altering the intestinal milieu, you see this picture here. And on the left is, quote, normal, or we called it during webinar number 1, eubiosis, right? And then in the middle, you have these potentially pathogenic bacteria. And on the right, you have an excess of these bacteria. And in summary, GI inflammation can be caused by infection, dysbiosis, food reactions, stress, alcohol, mold, liver backup, and more. The longer or more chronic this inflammation lasts, the more inflammation it causes, which creates endotoxemia and leads to chronic diseases. So we're going to catch it, we're going to reduce it, and we're going to keep track of it, right? Something that I encourage people to Make sure that they're fixing what you're seeking to fix. And most of us could do well to check once a year and see how our gut is behaving. Some people with more chronic conditions will need to do it a little more frequently for a while to make sure that things are going the right direction. This is talking about, again, from birth to 2 years old, how we're increasing the stability of the gut and increasing the diversity of the microflora. And we talked a lot about, again, full term versus preterm, mode of delivery, maternal weight and diet, hospital environment, contact with mother and healthcare staff, antibiotic use during pregnancy or in early days of life for the baby, and feeding choice, breast versus bottle, and factors that can affect the development and acquisition of gut flora in up to 2 years old. Again, that breastfeeding versus formula, use of a probiotic or prebiotic supplement for either mama or the baby, antibiotic exposure, timing of and weaning of food choices, home structure, a number of siblings, and I would say animals in the home. And that's not a bad thing. Those things help improve the diversity. So, and being raised on a farm. Kids raised on a farm have a more diverse gut microflora as well. So this little diagram is talking about when you're born, your species poor and unstable. Okay. And so it's what you're exposed to in the intervening months, days, years, breastfed, et cetera, that's going to impact whether or not you're moving towards that healthy, stable state where you're species rich, complex metabolism, and inflammation sensitive. So your body can respond to inflammation. Once that inflammation has been there for a while, you become inflammation tolerant, which means your body's allowing that inflammation. It's not responding properly anymore. Okay. So you can see that line that goes down to the left, which is red. It's called an acute disturbance. So it happened sometime recently. Okay. And you can have a degraded transient state where you become species poor and unstable. But you can see there's a green line that goes right back up that says complete recovery, and you go back up to healthy, stable. Okay. But if you stay in that degraded transient state, species poor and unstable for a while, you can become chronic. Okay. You have incomplete recovery, or you have a secondary exposure. Maybe you have an autoimmune flare, or you get exposed to a food bacteria that your body can't handle, and it pushes you further to the right. And that's where you get to the degraded, stable state where your species poor and you have a simplified metabolism of your gut microbiota. That's where you're going to start having your inability to metabolize and absorb nutrients. Okay. And that's where you have that inflammation tolerant that we talked about. So again, that's where you're going to start your chronic inflammation, your inflammatory bowel diseases, your autoimmune diseases. Okay. So again, we need to get you back on that path. I think we pretty much talked about all that. So functions of bacteria in the microbiome, that's all review. Microflora functions in the gut. Those metabolic activities that you hear me talk about, okay, that's how the microflora is fermenting non-digestible dietary residue, releasing the short-chain fatty acids, helping to absorb the vitamin K and some glucose, okay. Trophic activities, that's where the short-chain fatty acids that are produced by the microflora control epithelial cell proliferation and differentiation of the colon. So that's protecting against developing neoplasia. It's protecting against inflammation. And then the protective activities is the barrier effect. So the resident bacteria provide resistance to colonization by exogenous, potentially pathogenic microbes. Now remember, when we looked at page 3, what did I tell you guys? If those are high, I don't necessarily call them infections because they're not pathogenic per se, but they're colonizations. Okay, so that kind of ties into here to what we're talking about. So this is again talking about the role of the commensal flora in preventing allergenic reactions. And all right, now back to page 4 under your health markers. The next marker there that we haven't talked about is called beta glucuronidase. You heard me mention a few times that the liver plays a critical role in the health and well-being of the bowels as well because of the bile. And now we're jumping into this one. It's called beta glucuronidase. It's a marker of inflammatory bowel disease and increased colon cancer risk. It's an enzyme produced by the liver, also produced by kidneys, spleen, intestinal epithelium, endocrine and reproductive organs, but also certain intestinal bacteria can make it. All right, so intestinal bacteria may be jacking your numbers up. It's in more physically active, I can't say that. The beta glucuronidase is generally more physically active in men between the ages of 25 to 50. Estrogen tends to be a protective factor until the onset of menopause in women when the estrogen is decreasing. In children with IBD, beta glucuronidase is often low. However, I've had a lab on a 7-year-old child with Crohn's where the beta glucuronidase was off the charts. So I don't rest on that always being the case. But this beta glucuronidase, what does it do? Okay. It slows the conjugation and removal of potentially harmful substances like hormones, say estrogens, drugs, any prescription or over-the-counter drugs that you're trying to metabolize, and carcinogens. So to be honest, I don't like how broad the range is for the beta glucuronidase marker on this test. I really like to see it 500 or lower, okay? If it's above the 2486, which is the level that they have marked there, it's definitely high. But if it's over 1500, I'm already looking at that as a something that we need to support so that it doesn't get to the place where it's high. Because when you stop conjugating and metabolizing or detoxing hormones, drugs, and carcinogens, you're putting yourself at higher risk for cancer and other estrogen-related problems, especially prostate, breast, colon, and other. Okay? So the question coming in right now, do we want the beta glucuronidase to be on the higher or the lower? Lower. Lower is better. Yep. Okay, so support and elimination and detoxification. So bowel transit time and microbial diversity, key, okay? Maintaining a steady turnover of bacteria and colonic cells appears to be a healthier milieu achieved by regular bowel movements and transit time. So those are the probiotics. Again, they're gonna help improve transit time. So if somebody leans towards constipation, they would have a different probiotic that they could use rather than someone who leans towards diarrhea, okay? Colonic bacteria metabolites in liver. Low choline can lead to liver disease. Dysbiosis leads to microbial utilization of dietary choline. So again, the dysbiosis can be eating up your choline, guys, reducing its availability to the liver and development of non-alcoholic steatohepatitis. So again, dysbiosis can eat up the choline, so we get cholestasis or stagnant bile, and we develop non-alcoholic steatohepatitis. Eesh. Okay, levels of gamma proteobacteria, and that's just a couple different bacteria, could predict susceptibility of an individual to develop non-alcoholic steatohepatitis from a low choline diet. Dietary choline affected levels of these bacteria. All right, so we talked about that. We talked about possibly using choline as a replacement while we're treating the dysbiosis, right? Improving constipation, diet, and lifestyle. We talked about the water. We talked about the fiber, right? Those veggies and plants. A report from IOM said that only 3% of Americans are consuming adequate amounts of fiber, and average consumption is only about half the recommended amount. That's why we're getting elevated levels of colon cancer. We're not getting the crap out, literally. Sorry, each fiber. Flax seeds can be exceptionally helpful. They're an important omega-3 fatty acid, but they can help with constipation due to its combined fiber and mucilage and oil, which adds both bulk and lubrication. I recommend freshly ground. So if you buy them already ground, they go rancid too fast. I recommend that you buy them whole, you keep them in the fridge, If you have an old coffee grinder, you can grind up like a week's worth, maybe, a tablespoon to 2 tablespoons per day. Grind up a week's worth and store it in like a glass jar in the fridge. Use your week's worth and then grind some more next Sunday, right? Psyllium seeds or seed husks. The husk and whole seed powder is very high in soluble fiber and has extremely high water holding capacity. So it increases both stool frequency as well as stool weight. So that means it grabs up other stuff and helps get it out. Okay. Glucomannan is a highly viscous fiber derived commercially from the tuber root of Amorpholis konjac. And that one we have to be careful, no more than 5 grams per day in kids. And then there's things like the guar gum, apple, or citrus pectin. Physical activity, walking helps stimulate bowel motility. We talked a little bit about stress and the HPA axis dysfunction. We talked about using the herbs, and we'll talk a little bit more about that in a minute. Osmotic agents, they're listed there. Okay, magnesium is one of the best ones there. And then botanical stimulant laxatives. I would say avoid these as much as possible. Find out the other problems and fix it. Don't rely on the botanicals to force a bowel movement. Okay, so moving on to gut barrier function. Basically, we need an intact, strong barrier. This is showing that on the left, when we have a normal bacterial function, the pathobionts stay where they're supposed to stay and they can't get across and into the bloodstream. But when that gut barrier is working well, the bacteria can get through and into the bloodstream and, again, soak in food particles, right? Intestinal permeability or leaky gut refers to the breakdown of the intestinal lining and subsequent leaking of particles and substances into the bloodstream. It can be caused by stress, including adrenal fatigue, that can be also caused by food, pathogens, physical or emotional stress, alcohol and other chemicals, including glyphosate, medications, including antibiotics, NSAIDs, birth control pills, food additives, preservatives, and emulsifiers, which we talked more about during the first webinar, food allergies, nutritional depletion, and intestinal infections such as bacteria, yeast, or parasites. Triggers that can influence leaky gut, lifestyle factors, which we just talked about, gluten and dairy sensitivity, food allergies, low secretory IgA, which again, we're going to talk about that in just a minute, but check on page 4 for your secretory IgA levels, immunosuppression, post-infections, or surgery. Degradation of gut lining allows excessive absorption of toxins derived from the chemical activity of intestinal bacteria, stressing the liver. The symptoms produced by excessive intestinal permeability may be limited to the abdomen or may involve the entire body. They may include fatigue and malaise, joint and muscle pain, headaches, and allergies. So stages of leaky gut, it starts with local GI symptoms and can worsen over time as the intestinal lining is destroyed. The initial onset is usually accompanied by food allergies or food sensitivities, okay? Progression is insidious. People ignore the initial onset usually, and as time goes on, IgG reactions are starting. They can develop autoimmune problems, headaches, joint pain. Common autoimmune conditions associated with leaky gut. They occur as the antigen-antibody complexes build up and immune system begins to attack itself. Things like eczema, Hashimoto's thyroiditis, Crohn's, type 1 diabetes. Adrenals are responsible for secretory IgA production. So if your secretory IgA is low, that's something we need to talk about. Stress diminishes salivary and blood levels of IgA. And the more beat up the adrenals, the more GI issues you're going to see. Irritation in the GI then causes higher levels of secretory IgA or inflammation of the gut lining, which further stresses the adrenals. Vicious little cycle there. Symptoms of intestinal permeability or leaky gut, allergies, food intolerances, fatigue, generally just not feeling well, muscle pain, fevers, abdominal pain or distension, diarrhea, skin rashes, brain fogginess, poor exercise tolerance. And then your secretory IgA marker. The two main immunoglobulins found in mucus secretions, including tears, saliva, sweat, colostrum, and secretions from the genitourinary tract, gastrointestinal tract, prostate, and respiratory epithelium. It's the first line of defense. It's initially provided in breast milk and gradually stimulated by an infant's developing gut microflora. So remember, we talked about that developing infant and all the things that impact how they're developing the diversity of their gut microflora. And if they have those early antibiotic exposures, they never get to develop this properly. Okay. Choline, again, there it is again. Choline, essential fatty acids, glutathione, glycine, phosphatidylcholine, vitamin C, and zinc are all needed for secretory IgA production. And then we have your, so real quick on that, I'll just give you some lowdown. Low levels of secretory IgA, several of you have them, can be caused by lack of breastfeeding, immune suppression, autonomic nervous system imbalance, chronic stress, damage to the intestinal barrier, which again, you can go back a couple slides and see what are all the things that can do that, chronic GI infection, food intolerance, gliadin intolerance, inflammatory bowel disease, corticosteroids, immune suppressing, and anti-inflammatory medications. Okay. High levels of secretory IgA, which a few of you have, can be caused by acute stress, intestinal barrier dysfunction, acute oral infection, acute GI infection, heavy smoking, alcoholism, periodontitis, dental plaque accumulation, or chronic systemic infection, things like Epstein-Barr, cytomegalovirus, HHV, HIV. Treatment for the secretory IgA needs to follow addressing of the root cause. Okay, so we'll get into that more. So anti-gliadin IgA is a subclass of IgA, and this is specifically a response, an immunoglobulin response to gluten. Okay, so if secretory IgA is low, your anti-gliadin IgA may not be appropriately measuring. So if you have a low secretory IgA and a normal anti-gliadin IgA, it might not be telling you the whole truth. Okay? It might be a lot higher than what it's reflecting at this moment in time. That's what I'm trying to tell you. Okay. So anti-gliadin IgA, if it's high, it means your body is producing antibodies, immunoglobulins against wheat and other grains that contain gluten. Okay, so honestly, I'm going to tell you right now, some of you actually have it high, like flagged high. Others of you, you're on the cusp. I want to see that below 50. Because if it's above 50, you are producing antibodies. And at the next time that you get exposed, it's going to increase your zonulin and cause a leaky gut. Okay? So be careful. Gluten is not helpful nutrient for any of us. There are foods that we can eat that do not contain gluten that will provide what our body needs nutritionally speaking. Gluten doesn't improve the health of any of us. So gluten reactivity can encompass celiac disease, which is still not an allergy. It's an IgA reaction, and in the United States, only IgE reactions are considered allergies. So celiac disease or non-celiac gluten sensitivity. And I'm telling you right now, if your level is considered, quote, high there, you see that, we're going to have an ongoing conversation about whether or not we need to test you to figure out whether or not you have celiac disease or non-celiac gluten sensitivity so that you understand the potential ramifications and need to cut out gluten. If you don't feel like you need to be convinced, then you simply just do it, okay? Non-celiac gluten sensitivity can still cause what we call gluten encephalopathy or inflammation of the brain due to the immunoglobulin response. And that can cause systemic inflammation, arthritis. It creates white matter lesions that could lead to OMS and other problems. So Dr. Terry Wahls did a phenomenal experiment on herself. She had MS and was wheelchair bound and knew that she needed to keep her job because she was the sole breadwinner in the family. And she put herself on an extreme diet. It is extreme, but she reversed her white matter lesions in the brain and got to walking again after she'd been wheelchair bound. And that has never happened before with MS. So the doctors have studied her. She's written protocols, done additional. They gave her money to do more research on other people to see if it does it just work with her. Is she unique, or does it work with other people? So I'm telling you, if you have inflammation showing up right there on this little test that you did, it's a cheap way to tell you you cannot have gluten. Okay. So zonulin. Zonulin was an optional add-on marker to the GI map test. And zonulin is a protein that increases permeability in the epithelial layer of the small intestine by reversibly modulating the intracellular tight junctions. So hear me on this. Zonulin goes up, it opens the gut barrier, which we talked about, lets out proteins, lets in bacteria, all these things can happen, right? But then it can go back down again, okay? It's a marker of permeability in the epithelial layer of the small intestine, or leaky gut. It is elevated in cases of Crohn's disease and in smokers, celiac disease, type 1 and type 2 diabetes, and many cases of Parkinson's. However, zonulin goes up in all of us every single time we eat gluten, even if we're not gluten sensitive. Do you hear me on that? So even one meal can cause your body to let in pathogens and let out proteins that cause allergic reactions and food sensitivities because you ate gluten. So, yeah. Other conditions associated with increased intestinal permeability include food intolerances, acute pancreatitis, migraines, cholelithiasis, which is gallstones, a variety of autoimmune conditions. Nutritional treatments for the hyperpermeability include hydration, fruits and vegetables, high fiber foods, digestive enzymes, and probiotics. If you have a leaky gut, you have a leaky brain, period. They're attached. That blood-brain connection we're talking about, the barrier is synonymous. So causes can be gluten, other food allergies, alcohol and drug use, nonsteroidal anti-inflammatories, stress, infections, environmental toxins. Symptoms of a leaky brain can include depression, anxiety, brain fog, headaches, or insomnia, Alzheimer's, Parkinson's, dementia, multiple sclerosis, ALS, seizures, chronic fatigue syndrome, or autism. Treatment to heal the critical blood-brain barrier is important to address the gut as well. Balancing blood sugar, managing stress, strict gluten-free diet, whether gluten sensitive or not, determining and removing other food sensitivities, and providing brain support. So this gut-brain connection we've been talking about, we have what's called the enteric nervous system, and it's literally a second brain in our body. It's a subdivision of the autonomic nervous system, and the autonomic nervous system is responsible for our base body instincts, and it has two branches: the sympathetic, fight or flight, and the parasympathetic, which is responsible for our breathing, our resting, our digesting, and our sexual arousal. And that communication occurs through the vagus nerve. So if our vagus nerve is disrupted, we don't take deep breaths, we don't feel rested, we can't digest our food, and we, generally speaking, don't have sexual arousals. Okay? Because if we're running from a bear, those things, those parasympathetic things shut down. We don't need to be resting. We don't need to take deep breaths. We're shallow breathing, right? We're doing fast breath. So anyway, the enteric nervous system can operate independently of the brain and spinal cord. Autonomic neuropathy of the GI tract may represent a primary disorder, but it's often secondary due to systemic disorders like diabetes mellitus. So the enteric nervous system is responsible for bowel regulation, serotonin production, our, quote, gut instinct. Sensory reception from the bowel is an important component of IBS. We talked about that visceral hypersensitivity. 90% of vagal fibers carry messages to the brain, so only 10% of them are carrying them to the gut. The vagus nerve uses neurotransmitter acetylcholine Again, that's that choline we've been talking about. It gets converted to acetylcholine in order to support the vagus nerve. Mercury blocks the action of acetylcholine. Botox is a toxic substance that has the power to damage the nervous system and shut down the vagus nerve. So symptoms of issues here can be chronic gut motility issues, sluggish bowels, somebody who needs coffee or magnesium citrate or laxatives in order to induce a bowel movement. And if your food doesn't move, it ferments. It sits there and putrefies, okay? There's a video out there from Dr. Datis Karazian called Gut-Brain Access that teaches you how to do things to stimulate your vagus nerve, like gargling hard, gagging, singing, things that are going to stimulate that vagus nerve to get it moving again. Diagnosing GI issues, so things like, well, what you just did, you did a test. There's pathogens and microbial flora testing. We did PCR or polymerase chain reaction testing by GI map. There's other tests out there we talked about before that do growth and stain culture or other systems of testing for pathogens. And we talked about the problems there. There's antibody responses to inflammation, things like Vibrant Wellness's Wheat Zoomer or Cyrex Arrays 2 and 3 to look for the antibodies. There's food sensitivity testing. There's elimination diet, and there's IgE food allergy testing and IgG food sensitivity testing. To improve your microbial diversity, we're going to use prebiotics, right? We talked about the importance of prebiotics for diversifying. Eat a wide variety of multicolored whole plant foods and fibers weekly, daily, including resistant starches, polyphenols, prebiotic-rich foods, prebiotic-like foods, mucilages, pectins, soluble and insoluble fibers. Our goal is 40 different whole, minimally processed plant foods per week. It's not that hard, guys. It sounds crazy hard, but it's not once you start thinking about it, because even a salad, even a small salad, okay, side salad on your plate could include 10 different things. A couple different leaf lettuces, maybe some shredded carrots, maybe some jicama or a couple green olives, or come on, we can get creative, right? We can think about it. Improving microbial diversity, stick your hands in the dirt. Live on a farm or do lots of gardening. Now, the one preface there would be a garden where you don't use glyphosate, right? Don't put Roundup in there because it's going to kill everything and it's going to hurt you. Eat more raw fruits, vegetables, nuts, and seeds. We did have a question coming in earlier about raw fruits, vegetables, and seeds, so we'll talk about that. If you currently have reduced gastrointestinal function, your body may not tolerate a lot of raw fruits, vegetables, nuts, and seeds. So start with them sprouted or cooked, right? And gradually start to build the amount of raw that you can tolerate. And now here we are in summer. Our bodies typically tolerate more raw foods in the summer than they do in the winter, because our body just needs those warmer foods to really help warm up our body in the winter. Exercise moderately as opposed to intensely, because super intense exercise actually can cause leaky gut. Polyphenol-rich foods, again, here's a list for you, but they're always plants. Polyphenol-rich foods are always plants. Prebiotic-rich foods, again, we talked about foods rich in oligofructose or inulin, the FOS and GOS. Things like Jerusalem artichokes, yacon tubers, burdock root, chicory root, dandelion root, garlic, onions, leeks, asparagus, globe artichokes, all have fructooligosaccharides in them. Okay. Galactooligosaccharides are going to be things like legumes, brassica family vegetables, fresh beans, beetroot, rye if you are gluten tolerant, okay, and sunflower and pumpkin seeds. Prebiotic-like or colonic foods include things like brown rice, carrots, black currants, dark cocoa powder, almonds, and green tea. We talked a little bit about butyrate. It's the primary short-chain fatty acid. It's produced by a healthy gut microflora, but it maintains and promotes intestinal barrier integrity. It decreases endotoxin absorption and decreases abdominal pain and sensation of fecal urgency in patients with visceral hypersensitivity. It enhances colonic motility. It enhances insulin sensitivity. It protects us against neural cell death. It upregulates mitochondrial function. It attenuates endotoxin-induced neuronal inflammation. It upregulates brain-derived neurotropic factor, and it decreases systemic inflammation. The long and short of it, guys, if you're hearing all of this, lactulose is one of the best things that we know that increases butyrate, right? Because all the research we've seen on lactulose does all of those things that we just read. Diets that decrease butyrate production, okay, diets that restrict fiber and plant foods are SAD, Western style diets, some versions of keto and paleo and AIP, diets that are high in fat, and diets that are high in protein or low in carbohydrate are going to reduce butyrate and decrease populations of butyrate producing bacteria. So we lose all those benefits that we just talked about on the last 2 pages. So despite the fact that these things are out there and they're fads, they're not necessarily what's going to cause you to have a healthy, happy longevity and health. Okay. So dietary strategies to increase butyrate include psyllium husks and seeds, partially hydrolyzed guar gum, insulin, or that should be inulin phos as food or supplements, lactulose, legumes, dietary polyphenols, we just talked about those, and resistant starch. There's 4 types of resistant starch, the long and short of it, again, plants, okay? And you're gonna get a different type of starch if you cook and then cool, like say rice or beans. You're going to get a different fiber if you cook and then cool them and eat them cooled. So RS1 is in grains, seeds, and legumes, resists digestion because the starch is trapped within the cellulose walls. If it's finely milled, there's less RS content. Cooked oats versus soaked oats. Soaked oats actually have a higher level of this RS1. So if you made what they call overnight oats, it's going to have a higher level of this resistant starch in it than if you made oats on the stove. It doesn't mean not to make oats on the stove. It just, I'm trying to tell you, you get more RS1 out of the ones that are soaked. RS2, highest amylose content found in raw potatoes. I don't know about you, but that sounds nasty. There's actually a supplement for it, but raw potatoes, plantains, green, unripe bananas, and legumes. Cooking makes the starch, the starch digestible, and the predominant form is found in supplements and functional foods. Again, because this one's pretty hard to, how many people are going to eat raw potatoes? RS3 is formed when certain starchy foods are cooked and then cooled. It's called a retrograde starch. So root vegetables, whole grains, legumes, black atsuki, fava, and kidney beans, red lentils, chickpeas, and dried peas. So in other words, you may cook a rice and then cool it and make like a rice salad out of it. Or you may cook a legume and then throw it on top of a salad when it's cold, right? So you're just going to get a different type of starch. And the last one's called RS4, and that's a human-made starch via chemical processes. Sorry, a lot of stuff tonight. I tried to warn you. But again, I'm going to ask you the same question I asked you during the first webinar. What are you doing here? What do you want to achieve? Do you want to feel good again? Do you need more energy? Do you want to better absorb nutrients that you're eating? Do you need to reverse autoimmunity? Are you ready to work for this? Because it takes, you heard me in these presentations. It's not about some pill that I'm going to encourage you to pop. There's really a lot of lifestyle that's going on here. And for some of us, these processes of inflammation have been going on since we were born. I told you I was one who reacted to dairy from day one, and the doctor simply told my mother I'd grow out of it. Well, guess what? My body desensitized, so I no longer felt the inflammation, but the inflammation raged on. So many of us have been programmed for inflammation from early childhood, if not from birth. Okay. So my little comic here, give it to me straight, doc. How long do I have to ignore your advice? Well, that's up to you, because right now you get the choice. I'm not going to tell you you have to do anything. You get to decide what you want, but what you will allow is what will continue. So when we have talked through a lot of these webinars, I've mentioned products and things, and if we have time here, I'm going to put up a sample wellness program that'll show you guys kind of how I structure the wellness program so you'll know how to read it when we talk about you. And many, but not all, of the supplements that we're going to talk about can be found at a place called Doctor Supplement Store. And in order to, it's not my store, but in order to get access to it, you have to have a physician's access. So the codes that I provide here, the registration code, that will get you into my quote unquote store inside of there. You'll get access to it through me. And then that promotion code that's listed at the bottom has to be used if you want to save 10% off of your order and if you want free shipping over $50. Otherwise, I think it's free shipping over 100. So yeah, just trying to pass on some savings for you there. And just in general, be careful of what or where you buy things. If it's not from the manufacturer, be careful. So some products that we talk about during your wellness talk may be something that we have to get over Amazon, or there's other stores like online from Walgreens or something that I'll tell you where you can get it. But I'm going to tell you, even if we're doing it from Amazon, that you make sure it's coming from the company that produced it and not some knockoff, because we don't know if it's the original product or not. Okay. Yeah, so I'm encouraging you to join me. Let's do this thing, right? There's an apple for you. I will offer also a GI Healing Mastermind. I have a Facebook group that I have started that is closed. It's not secret, but it's closed. So you can find it, because if I'm not your friend on Facebook, I can't automatically add you. But it's I'll have to tell you the exact name of it because it's not even on here, but it's basically 60 days of intensive support there, so that if you have questions on your wellness plan, you have questions, there's other folks there that have participated in the webinars in the past. There's also conversations there that I've had in enhanced discussions about some of the things we've talked about here. Yes, there's definitely more to talk about. Ordering information for lactulose, things like that, is all there as well. So yeah, that's just some thoughts for you there. The mastermind is going to get started. I apologize, I didn't update the date on the last set of slides. The mastermind will get started August 1st. So, in a little less than a week, I'll open that up. So hopefully you'll have a chance to get your labs. There's a couple of you that are still waiting for your labs to come in. And when your lab comes in, I would very much like it if all of us can get together for your one-on-one calls or consults within the next couple weeks, so we can get you moving on. Okay, let's get you on a path to healing. Yeah. That's the end of that. So let me get to the questions that were sent in, and I know you guys have been putting more questions in than I could keep up with tonight. I promise I will try to get there. So what are your thoughts on green juicing to improve nutrient uptake? I use cucumber, celery, green apple, lime, and ginger. So yeah, I don't have a problem with some juicing, and I like the combination of nutrients that you're using there, especially if they're organic, right? Because if you're using a lot of celery and apple and things, you're juicing it, so you're concentrating it. If there's toxins in that fruit or vegetable, you're going to get it more of it. So careful. And the other thing is I don't like saying to use those instead of eating the vegetables and things, because we're missing all the fiber and some of the other nutrients. So it's okay. It's good. You're going to get a shot of quick nutrients there, but we're still missing a lot of the other pieces that we need. Make sense? Because of poor digestion, I've been advised against eating raw vegetables. Do you agree with this advice? So you heard me say, some raw, some cooked, and as you're healing your gut, you can increase the numbers of raw veggies that you're eating, but you may need some more of those different types of fiber that we talked about. Remember the different starches? So kind of take a peek there and see what you're missing, because a lot of people have been cutting out entire classifications of foods because of these popular diets that have been advised. And when you cut out entire categories of foods, you're also sometimes cutting out entire categories of resistant starch. So that's going to cause bowel issues too. What's the significance of strong positive for candida on an oat but negative on a stool test? Good question. So, on a stool test, we're looking for the presence of candida specifically in the colon. You may or may not have it in your upper digestive tract, and it may not show up in your colon, or you may have it in your urinary tract or other organs, but it's not in your bowels. So, an organic acids test is based on a urine sample. So, again, it may be that you're someone who has had a history of urinary tract infections or other things that needs to be dealt with in that way. There's still probiotics and things that we can use for candida that's in the urinary tract but not in the bowels to help. Okay. If something is in normal bacterial flora category that's noted as DL, is this something I should attempt to raise? I think maybe you're talking about the commensal flora. And if it's a DL, I'm going to suggest that we use things like prebiotics to help raise it. Okay. Prebiotics, resistant starches, colonic foods. We're going to use things to help stimulate the regrowth of that bacteria as opposed to trying to do something direct or aggressive. Make sense? All right. So now let me scroll backwards here. If I don't knock the microphone off while I'm doing this. Patricia, you want to join the mastermind? So in Mind Body, do you guys remember how you got into Mind Body? You log in there. You will have the ability to select the GI Mastermind and register for it. And if you have difficulty, just message me through my professional Facebook page and I can help you do that as well. Okay. Mary Kay, I've done Dunwoody and Meridian Valley Lab. Food sensitivity testing, my results were wildly different between the two just within a few weeks. Yeah. So that's one of the reasons why you heard me say that, you know, there is no perfect test, but of the labs that are out there, the two that I like the most for food sensitivity testing, IgG, that we're talking about here, are Cyrex and Vibrant Wellness or Vibrant America. Those are the two that are the best. And they also do the celiac, non-celiac testing, the intestinal and brain barrier function testing, and things like that. Both the Cyrex and Vibrant Wellness both do those as well. What do you think about a healthy keto diet with lots of veggies and healthy meat choices and healthy fats? So, Matthew, I think I would alter that by saying, because these terms can be a little bit gray, and keto to one person isn't keto to the next person isn't blah, 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 right? I would almost say a quote healthy or a vegetable heavy paleo diet would be better in my mind than a keto, because keto tends to be heavy on the fats. And you heard me say in the webinar, I don't know if you got a chance to listen to the first webinar yet, but high fat or high protein diets in absence of those veggies can cause disruptions to the gut microflora. It's going to it's going to shift towards more inflammation. So when I say a vegetable paleo diet, I'm talking food from the earth, right? Not a lot of processed foods, but also not being so heavy on the fats. I hope that makes sense. We can talk about it further when we do your one-on-one call, but that was a really good question. I appreciate you asking that. And then let me clarify my answer, because men and women respond differently to these styles of eating. Women, especially women who've had a history of adrenal fatigue or are over the age of menopause, um, suffer greatly from reducing their carbohydrates too low. So again, I'm not talking starchy, refined, you know, bread. I'm talking about healthy carbohydrates from non gluten grains or from butternut, squash, beans. Um, why can't I think right now of all your, oh, sweet potato, purple potato, things like that. Women need more of those starchy carbohydrates from what I've seen in labs and patient symptoms. So I just kind of want to give you a heads up there as well. I'm going to scroll back up, see what else I missed. Um, been eating an Urban Remedy protein bar for 2 years and just found out it has green kamut, but they claim they're gluten free. Doesn't kamut have gluten? Um, Good question. I don't think that kamut is a grain that's automatically a gluten grain. I think it would warrant a call to the facility and ask whether or not they're certified gluten free facility, and do a little bit more research in that. I never um, trust but verify, right? Always check. I've had patients who were celiac and not healing, and we've had to dig into their spice cupboard, their other supplements. And there's some notorious companies out there who are not certified gluten free. Their facilities are not gluten free. And so there's a lot of cross contamination in some of their supplements. Oats is one of those you guys have to be careful of. Oats are threshed or cut on the same machines as wheat. So if you like oats, you want to try those overnight oats or things, make sure that you're getting one that's certified gluten free. It'll have to be made in a facility that doesn't use the same machinery for the wheat. Uh, any ideas how long one meal that raises zonulin would keep the lining? No, it's going to be totally different in each person. Hours, days, months, just trying to gauge how strict I am with gluten for your children. Really hard to say, Mary Kay. I'm going to tell you again, it helps no one. It improves the health of no one. So if you could help your children learn to understand the role that gluten has done in our diets. Now, let's talk. We didn't get into the nitty gritty of it, but 50 years ago, the wheat that we were growing in this country is not the same as what's grown today. The wheat that's grown today has 50 times more gluten in it. That's why more people become gluten sensitive or their celiac genes become expressive. It's one of the reasons. Is because the plant itself has been hybridized and has 50 times more gluten in it. So none of us can digest it. Some of us react to it. But all of us can have our zonulin impacted. And so we're still watching the research on that, Mary Kay, but in all honesty, it's not showing the same in everybody. So someone who has a gluten sensitivity, it could take 90 days. In someone who doesn't have a gluten sensitivity, but they had a heavy gluten meal, maybe they had a beer and they had a club sandwich, that might last them 12 hours. But if that same person was gluten sensitive, like I said, it could last 90 days. So yeah, there's a lot of variability there. I've been off gluten for a couple months. Will I be able to see my test whether I'm gluten sensitive? Great question. And we don't have the benefit of seeing yours yet to tell you. As you're healing, your antibodies or your immunoglobulins to the gluten are going to reduce. So if you know that you've been off of it for a couple months and we still see it like around 100, yeah, you were sensitive. If you've been off of it for a couple months and it comes in at a 20, I'm going to say, hoorah, like that's perfect. Your body needs that. Does that make sense? So it's not perfect in the sense that the immunoglobulins are developed when you eat the meal, when you eat the gluten. And so when you stop it, they start to heal. But someone who's celiac can literally take 2 years to get their immunoglobulins back down. So that's why I'm saying they may still be elevated because they're coming down, but we'll be anticipating seeing that answer. Is the measurement for zonulin most accurate on stool tests or other blood tests? Great question, Mary Kay, and the research is still out on that. Um, it's something that we're watching. There's a real close percentage of uh, reproducibility on the stool test. I think the blood test is more accurate, though. Yeah. What's the ideal range for secretory IgA? Seems too high and too low are problematic, but I'm not sure what the goal range would be. So honestly, I'm pretty comfortable with this lab's range. A previous lab that I used didn't show a low. They only had a high, which is really problematic because low can be immunosuppressive. So on this particular lab, we're looking at 510 being anything lower than 510 being low, and anything over 2010 being high. And I went through during the presentation and kind of talked about things that can cause the low and things that can cause the high. But together, the low secretory IgA and the zonulin both speak to concerns of leaky gut. But the low secretory IgA alone doesn't tell us if you have a leaky gut. It just puts you at risk of having leaky gut. Okay. Christina, you must have put that in when I was talking. I'm not sure. Does MTHFR make what high? Can't wait to start my castor oil packs. Awesome, Marcia. Yeah. So for those of you who don't know that comment there, castor oil packs can be super, super, super healing to the liver, to the gallbladder. It's something we can talk about at another time. We can talk about it in the GI Mastermind. But castor oil packs applied appropriately over an organ can really, really, really help with healing. So that's what Marcia's comment was about. Do you want the beta glucuronidase to be high? We said that. That one's low. We want the beta glucuronidase to be low. So Mary Kay, I'm just gonna, be kind of frank on this with multi-level marketing companies. I don't have an across the board blanket statement of one that I love or one that I don't love. What I'm gonna say is there's a lot of them that add folic acid because folic acid is cheaper than MTHF or methyl tetrahydrofolate, which is methylated folate. And folic acid is dead folate. It's like if you were to go out in the yard and forage for dead plants. And that's actually for many of us with MTHFR, it blocks our ability to get folate to our brain and other essential parts of our body. So not a huge fan. When it comes to polyphenols, though, there are products out there, and maybe even some by that company, that are just the plant and not any added nutrients that could be helpful. But remember what I said, it's all the parts of the plant that are helpful. So while the polyphenols do one thing, the fiber or the skin from that fruit or vegetable can do a whole nother thing. So it's always better to eat the food than to use the supplements. But again, when we're healing, we may need more of something than we can possibly chew in a day, right? So then they can help. I'm not sure I understand that question in parentheses, Mary Kay. I'm going up. Regarding SIBO, would you still give bifido probiotic strains to attempt to treat SIBO, even if the stool test, your level of bifidobacterium is high? Good question. I'm going to say we're going to get into that more one-on-one because I'm going to look at all the bacteria. Yeah, totally. I'm going to look at all the bacteria and see what's happening before we would make those kind of recommendations. Christina, your cat's wanting to talk to us too, huh? It's all good. We need to check on that question, Marcia, about culture being dairy. I don't believe that it is, but we can take a peek. Yeah, thank you, Christina, for answering that. Methanobacteriaceae. How much lactose are we talking about and taken for how long a duration? Great question. I didn't even address that. Let me pull up really quick for those of you that are still here. Give me 1 second on the screen. I'm going to switch what is showing up on the screen. I want to bring something up and show you. I'm not even sure if lactulose is on this, but I promised I would show you this. It didn't do it. screen share. Sorry. I don't know, maybe you guys are seeing it. Mine keeps jumping back to the same thing. Are you guys seeing? There it is. It is there. Okay. Control F. All right. So what you're seeing there is kind of an example of how your wellness plan would be laid out. And this was an example for somebody who has H. pylori. But again, we'll get into more specifics because none of you have any one thing all by itself. So with the H. pylori, these are examples of probiotics that have been shown to be helpful. That Annatto E Synergy is both vitamin E as well as black cumin seed, which has been shown to be exceptionally helpful with H. pylori. So we talked a lot about the zinc. We talked a little bit about the NAC, all being helpful there. The lactulose, if it was here, in research, it's been shown to be effective at up to 30 milliliters per day to help with the gut rebalancing, the glucose regulation, the improved lactobacillus and other things. So that 30 milliliters, up to 50 milliliters was used in adults specifically for non-alcoholic fatty liver. So the dosing went up when there was already liver inflammation and problems going on, but 30 milliliters was safe across the board. But I still encourage people to build that dose slowly and split it. So in other words, you would build up to 15 milliliters twice a day. That one doesn't have to be with food, but I typically say like, hey, breakfast and dinner, like so you can remember to do it during like a normal meal time. But those little measuring cups that you would use to take like elderberry syrup or some nasty cough syrup, those are usually milliliter measuring cups. And they start at 5 milliliters and they go up to like 20 or 25, depending on how big the cup is. And so 5 milliliters to start once a day, make sure your body tolerates it. Then you could move it to 5 milliliters twice a day. And then you could slowly build up the dose up to the 15 milliliters twice a day. Good question. Low elastase and normal steatocrit. It basically, Christina, it's talking about reduced pancreatic enzymes, but not so low that it's impacting your steatocrit level. And that may just mean that you don't have a super high fat diet. So it's not impacting you in that way. Yeah, but pancreatic enzymes are still going to impact your proteins and things too, right? We don't unfortunately have a measure of that on this test. If timing can be off with pancreatic enzymes and bile, would it make sense to try digestive enzymes with meals, even if your elastase marker is high, but you have steatocrit markers? I would say possibly digestive enzymes, but maybe it might be just a bile issue that we can work on. Yeah. So we'll dive into your labs a little bit further, but it might be a bile thing. Yeah. Because that's the one we talked about. Yeah, if the pancreas is good, but the steatocrit is a little bit high, it's usually bile. Is there a test to diagnose low stomach acid, or are you mostly determined by symptoms? Yeah, mostly by symptoms. And I also can see on like NutrEval testing on the amino acid levels and nutrient absorption. Yeah. Would the D-limonene only help while you're taking it for GERD, or just a 20-day regimen help to reset some other things? The D-limonene was pretty much for the symptoms. Yeah, for the symptoms of the GERD. It doesn't even heal the GERD, right? It just helps with the symptoms while you're fixing whatever the problem was that was causing it. Okay, yeah, Helen, I hear you. I notice that when I'm out eating, that I'm still sitting, chewing and chewing and chewing and watching others at nearby tables chew 5 to 7 times. Yeah, because the average in US is 6, right? And sometimes it can even be frustrating because people that you're eating with eat super fast. Like I'm really self-conscious that everybody around me is done and I still have like a half a plate of food. And sometimes I'll just be like, oh, wow, I'm already full. And I'll just get a box and take it to go. So I'm not sitting there still eating while everybody else is done. Maybe I should just not care, but yeah, sometimes I'll just take the rest of my meal and eat it later because they were they were still done. Um, what's the difference between hydrochloric acid and elastase? Okay, so hopefully you heard that, Christina, in the conversation, right? Hydrochloric acid is produced in the stomach and it breaks down proteins. Elastase is produced by the pancreas. So the different purposes. All right, cool. I think I got through all this. Let me scroll back down and see if any more questions have come in. Currently, I'm allergic to beef. Chicken doesn't work either. I've been an unintentional vegetarian for a year. I'm going to run into flora diversity issues without meat. Okay, so Mary Kay, maybe, maybe not. I am I think it would be safe to say um, a plant-based eater. I don't eat a lot of meat. I eat a few eggs and I eat a very little bit of fish, but I regularly run my nutrient markers and I have completely sufficient protein. So the question is whether or not you are both consuming enough of mixed plants in order to have complete proteins and how well your body is absorbing those proteins. There's also plant-based protein powders that can be used short term to help you increase if your amino acids are low. Um, and we'll need to talk further about whether that's truly an allergy, an IgE to beef, or whether you're having an IgG reaction to beef. There is a difference, and it matters when we talk about products that we're using and ways that we're helping you heal. So please remember to give me more details on that when we do your one-on-one. Okay. Uh, all right, Christina, sorry, I don't know what you're asking there. I think it had to do with clarification I was asking of a question above, but I was going the other direction. Oh, thank you. Can MTHFR raise beta glucuronidase? Not that I'm aware of. No. So MTHFR related issues, possibly, because people with MTHFR, especially MTHFR A1298C, tend to have more gut related issues. And there are certain gut pathogens that can raise beta glucuronidase. And also because it's a liver enzyme, and people with MTHFR in general tend to have more detox related issues. So indirectly, sure, MTHFR could have an impact. Yeah, I just not directly. So hopefully that made sense. All right, guys. Tonight was super long. I apologize for those of you that are still hanging out. I hope I answered all of your questions sufficiently. Don't hesitate to write them down if you have more, because each of you will have your 45-minute consultation and we can dig into more of your specific markers and any questions that you have that maybe you thought of after we get done with the talk tonight. And if you had to cut out early and you're not here, I look forward to your listening to the recording. And please, please, please do schedule your individual 45-minute consult coming up pretty quick in the next couple weeks. A, because I want to do it while your results are fresh. B, I want to do it while this information is fresh in your mind, because there's a lot here and it's a lot to hold on to, right? It's like probably 10% got stuck in your brain. The rest of it's already gone. So I want to talk to you while it's still fresh. And I also mentioned during the first webinar that I'm going to be gone for a few weeks coming up to visit my son who's coming home from a deployment. So I certainly don't want you waiting on hold while I'm out of the office. So I definitely will be able to take care of you all before I go. And even those of you that are still waiting, there were 2 of you that are waiting for a test to come back because it got submitted a little late. We'll still be able to take care of you when that comes back. So don't worry about that. Just as soon as we alert you that your labs are available, let's get you on the calendar. Okay. All right, guys. Thank you again for participating. And I look forward to supporting you coming up in the next few weeks. Take care.